Go to.
Okay, I think I did, Lopa.
Okay, perfect.
Okay,
and if
perfect.
I would request everyone, please mute yourself, please, so that we can hear the speaker clearly. Kindly requesting each participant to please mute yourself so that we can hear the speaker. It's our kind request on behalf of everyone who is attending the session. Thank you so much.
Okay, great. Thanks, Lopa. So when you take a look at these three syndromes, you say to yourself, well, there isn't much that's specific. And in fact, it's very, very common to see fevers, cough, or whatnot in not only coronavirus, but in the typical colds that we typically get, as well as the flu. And so it's very, very difficult to really base on symptoms alone to determine whether or not you've got COVID or not, and testing is going to be important. So there are certain individuals that are at higher risk of having really bad outcomes related to COVID. Now, everybody, as far as we can tell, short of the kids, are as susceptible to being infected as anybody else. But once you get infected, certain individuals have a higher risk of developing severe complications from COVID compared to others. And these are sort of the lists of the conditions that predispose an individual for high-risk complications. So one is older adults, individuals who are 60 to 65 years of age or older. And in fact, when you take a look at some of the early New York, New Jersey, and Connecticut data, 8 out of 10 people who actually died from COVID were over 65 years of age. But in addition to just simply being older, there are a number of comorbidities that have been identified to also impart increased risk for complications. So again, as I mentioned, these conditions increase your chance of having a severe outcome of COVID, but it doesn't necessarily increase your chance of getting COVID compared to someone without these conditions. So Dr. Park will probably talk a lot more about sort of the issues around cancer. Active cancer is known to be a risk for having more severe complications related to COVID. It's a little bit of a debate whether or not a prior history of cancer and not being actively treated with cancer is a risk. Cardiac conditions like heart failure and things of that sort, or chronic kidney disease. And in terms of the other lung sort of and pulmonary things, COPD, cystic fibrosis. There's some debate about whether asthma increases your risk of having more severe complications. And it seems that those individuals who have the allergic type of asthma are at less risk than those who have asthma that are non-allergic in nature. But then maybe as others have mentioned, diabetes, any sort of other comorbid condition that increases the susceptibility to being immunosuppressed or being compromised in some way or form to combat the virus. Now, on a 30,000 foot level, this is sort of where we stand. You know, COVID's been around since the end of December, early January. And right now, globally, we've topped 14.5 million cases across the world. The top 3 countries currently are US, Brazil, and India. India reached over 1 million cases just over this weekend, as you may know. And today reported their highest daily new case rate of about 40,000 across the country. And so with regard to the US, we unfortunately are seeing these infections continuing to rise. There's been early evidence that the hospitalizations and the death rates are ticking up a little bit. The hope is that it's not going to be as severe as what we saw in the March-April timeframe when we had our first bout. And then across the different states and territories, last week there were about 39 of them that had an increase in their rate of infections, 12 plateauing, and 3 going down. And this week there's been about 43 going up, 9 plateauing, and 2 down. And the only 2 states that are actually going down are actually Delaware. Sorry for the typo there. Delaware and Maine. The hot spots that people are really focused on right now are Arizona, California, Florida, and Texas, because those are the areas where we're really stressing the healthcare capacity and taking care of folks. You know, many of the hospitals are at 95 to 100% capacity, and the ICU beds are very full. The maps that you see on the bottom give you just a sense of how dense the infection is across the country, as well as how fast they're growing in each of these areas. And so the picture on the right here, as you can appreciate, is the cases per capita. The majority of the cases, in terms of cumulative cases, they're highest in the Sunbelt region, as you can sort of appreciate. The darker shades are more dense cases, lighter shades are fewer cases. And then on the right picture here, you can see where the areas of the country are growing the fastest. And so the darker areas are growing faster than the lighter areas. And so as you can sort of appreciate, the areas here in the Sun Belt have a good amount of cases, and those are also in particular the areas where we're seeing the COVID growth the fastest. Fortunately, places like New York, New Jersey, and Connecticut, where there was a big number of cumulative cases early on in the March timeframe, it's not very, very fast in terms of their growth, and they're doing a really, really good job keeping things at bay. In fact, New York City is going into phase 4 of their relaxation of restrictions this morning. So we'll see how well they keep the infection growth at bay over time. Now, across the world, in Asia particularly, China's done a very, very good job, but they've actually had some, as you know, very draconian measures to really combat and keep the virus down. You know, when it broke out in Wuhan, they went door to door to every person's house to see if they had a fever or if they had signs and symptoms of COVID. And if they did, they pulled them out of the house and quarantined them in a centralized place away from their homes. But they were able to sort of keep that under control. Hong Kong, unfortunately, is in its 3rd wave now. And, you know, here we are in the US talking about 70 to 75,000 new cases a day. They're sort of in the 90s to hundreds range. But nevertheless, they're sort of seeing a 3rd wave of the infection. In Tokyo as well, they sort of last week went into red alert. Just gives you a sense of just how difficult, you know, keeping this virus under control is, especially if people are still traveling in and out and it's not homogeneous with regard to the viral control across the globe. Spain is also experiencing some new outbreaks. There's some concern that France might as well, because last week they celebrated their Bastille Day celebrations, which is equivalent to our July 4th celebrations. So we'll have to see how things go. But the story sort of around the world is really in India, where last week they crested over 1 million cases. It's a really, really cautionary tale of making sure you do the right thing at the right time. Because as you remember, when things started breaking out in early March, there weren't a whole lot of cases in India. They weren't actually testing a whole lot, but nevertheless, it didn't seem like it. But the government locked everything down. And when they locked everything down, all the migrant workers from the central, highly dense cities started to migrate back home. And the concern, in hindsight, people are worried that that was one of the reasons why it rapidly accelerated the infection dispersion across the country, because these migrant workers were moving into the more remote parts of the country. So we'll have to sort of keep our fingers crossed that it doesn't get too bad, and the death and hospitalization rates don't become too severe. But everybody's very concerned that that India is going to be the 2nd most densely infected country in the world, because it's quickly reaching at least the rates in which Brazil is growing, as well as closer to the United States. So let me segue a little bit and talk a little bit about how COVID is transmitted. And one of the variables that people like to use in the news, and you might hear about this, is this thing called the R0. And the R0 is a way of measuring how frequent the infection is spread. So an R0 of 1, for example, means that for one infected individual, that individual tends to infect an additional person. And so you can see on this part of the figure, for one infected individual, they infect another person, and that person infects another person, and so on and so on. When the R0 is less than 1, it means that for one individual, you infect less than one person, so that it's not perpetuating or propagating across the population. And when the R0 is greater than 1, it means that for one given individual, you're infecting more than one person. So that individual who's infected infects one person, but then that thing starts to spread and spread and spread. And when you have a epidemic or a viral infection across the public health that has an R0 of greater than 1, that's when the virus spreads. And so the goals really are really try to keep the R0 less than 1, so that it stops and it terminates and it fizzles out on its own. And what we've also come to appreciate is that when we take a look at large populations, the spreading of the virus is not homogeneous. So in other words, when we say an R naught of 1, it doesn't mean that everybody in that population is spreading to one individual. It's an overall average of the population. And so this study that they did in Hong Kong when it first outbreak showed this phenomena called what people are describing as super spreader events. And so what is super spreading? Well, super spreading really is this notion that they've realized that 10 to 20% of individuals account for 80 or more % of the transmission of the virus. And so these are clusters of folks. So each dot represents an individual. And so this is sort of a group at a bar, as you can see. This is a group at a wedding. This was a group at a temple. And this is sort of just the general population. And so in some cases, you can see one individual affecting another individual, or one individual affecting potentially two individuals. But they're clearly clusters. So in this particular individual, they infected all of these folks here in this super spreading event. Or in this person at a wedding, they did sort of more than just one individual. So these are the ones that the healthcare officials are really trying to get a handle on. And this is one of the reasons why people say, look, don't get into these large, crowded, closed and quartered places, because these super spreading events is accounting for a large majority of the transmission. And so let me just sort of give you sort of a couple of other insights, and we'll talk a little bit more about the spreading in just a second. What we do know about the virus, and what we do know about what happens across the environment, is that heat, humidity, and UV really impact the virus's half-life, or how long the virus lives. And so, the Department of Homeland Security actually did this study several months ago with the virus, and showed that when you put the virus in hotter environments, in more humid environments, and expose them to sun, you can cut the half-life from hours to maybe 1 to 2 minutes. So being outside is a good thing with regard to minimizing the virus's half-life and how long it can actually survive. Fomites, which is a term that talks about sort of things or objects that could potentially harbor the virus, like your mail, or the spoon that you use to eat, or cups, or furniture. There was once concern, as you remember early on, that these viruses can land on these things and hang out for days. And that's certainly true still, but in terms of its role in transmitting the virus or infecting individuals, it seems to be less significant. And most of the infection that's occurring is really through respiratory droplets that we sort of emit when we talk, and when we sneeze, and when we sing. And so respiratory droplets are these things that are 5 to 10 microns in size, and the virus can hang out there and travel to another individual. And this is the reason why the current guidelines are to say you should be at least 1 to 2 meters from folks, so you minimize the amount of respiratory particles that actually get transmitted from one individual to yourself. There was also a recognition that these viruses actually can hang out in aerosol. And so what's the difference between aerosol and respiratory droplets? Well, aerosol is just particles that are less than 5 microns in size. And so aerosols are lighter, and so they can hang out in the air longer, and so they can literally circulate around and not fall to the ground like respiratory droplets based on gravity. Another comment as we're sort of driving into the fall season is, what about schools? There's been a lot of conversation in some school districts not even opening, shutting down, potentially opening, and then potentially reopening in some instances. It's a very, very complicated situation, and a very, very complicated set of issues that the people are trying to deal and wrestle with. One of the things that we do know is that not all students transmit the virus in the same way. Kids that are less than 10 to 12 years of age tend to have less risk for getting infected. And also, once they get infected, there seems to be less risk for them to transmit that infection. And there have been a number of studies in Germany, France, and in Korea to really describe this. And so that's one of the reasons why it's been a challenge for many of the school districts to really figure out what best to do. Do you close all the high schools and open all the elementary schools? Do you do nothing? Because some of the kids have siblings in high schools and elementary schools. You mix. The other concern has been on teachers. You know, about 24% of these teachers that are in these schools have a serious condition, like we mentioned earlier, either elderly or have a comorbidity that increases their risk for having a serious outcome related to COVID if they were infected. So what do you do with them, and especially if the teachers are exposed? And in which, especially amongst the school-age kids, in some families, especially in the Asian families, as you know, there are multi-generations that live under the same household. And if you take a look at across the US, about 7.3%, as you can sort of see here, have are school-age kids that actually have a senior citizen living with them. And if they bring the virus home, could potentially infect them and cause serious havoc. And then the last thing is that, you know, how much benefit can kids get by going back to school when we have to exercise very intense distance measuring, you know, social distancing measures. This is a picture here from Beijing from June as they were winding down their academic year. All these kids, which typically sit for lunch here on one bench, convening together and socializing together and learning from each other, are separated, as you can see, taking their masks off for food and quickly putting their masks on after they're done. And so to what extent is the value of being at school still there when you have to exercise so many of these severe measures to make sure we minimize the impact of the virus and the transmission within the school environment? Quick comment on testing. As you know, there's PCR testing, which actually looks for the presence of genetic material of the virus. And this involves sort of putting a nasal swab down your nose and throat and doing sort of a preliminary chain reaction test. There's also antibody testing where they can draw blood and to see whether or not your body has actually developed antibodies in response to the infection that has occurred. Much of the testing that the US government and health policy people look at is the percentage of the tests, PCR tests, that come back positive. And the World Health Organization has come around saying that we want to get at least 5% or below, which signifies that we've got adequate testing to really see whether or not the infection is growing, shrinking, or whatnot. And you can see on the left panel, these are all the states that are describing their percentage of positive tests. Majority of them here are above the 5% line, with a handful here below the 5% line. And then across the world, as you can see, the US in this graph shows the daily number of tests per 100,000 individuals on the x-axis, and the number of these tests that turn out to be positive. And the US by far is performing the greatest number of tests per 100,000 of the population, but is still just above the 5% mark. So hopefully with a little bit of help and a lot of cooperation with the community, we'll be able to get this bubble below the line and get us to an adequate point of testing availability. Last few things on therapies and things we can do. Well, first and foremost, as you know, as I mentioned earlier on the right hand, this is sort of what happens with airborne transmission of respiratory particles. When we talk, we spew countless number of different respiratory particles of various sizes, some of them smaller, some of them larger. And if you don't have a mask, everything just comes out. And so some of these larger particles will fall by gravity to the ground. And that's one of the reasons why humidity is actually helpful in minimizing transmission, because with the humidity in the air and the moisture in the air, once these particles come out of your mouth, they collect the moisture that's around them and get heavier. And as they get heavier, they fall to the ground and hopefully minimize the distance in which they can travel. But then if you wear a mask, you're not completely getting rid of all of the things that can be transmitted from your mouth, but you're getting rid of most of it. And so you still need to sort of distance yourself from individuals, even if you're wearing masks. But the masks significantly improve the transmission. Why are the masks important? Well, there's three main reasons. One of them is that there are folks who have COVID that, you may have seen this in the news, that are asymptomatic. In fact, upwards of 40 to 60% of people are believed to be asymptomatic, depending on the cohort that you look at. This is unlike other sort of viral infections like the flu, or you may have heard of the SARS about 15, 20 years ago, or even the MERS virus, where many of the respiratory viruses that we've seen in the past, people aren't infectious until they develop symptoms or several days after they develop symptoms. COVID is very different. You can actually be infectious 1 to 3 days before you actually start developing symptoms. And so you don't know that you're infected until after you've interacted with a number of folks and potentially have transmitted the virus in your nose or in your mouth or in your lungs. The second, and so the last one is that when you wear a mask, you potentially minimize the possibility of what we describe as self-inoculation or infecting yourself. As you know, if the COVID is sort of on surfaces or on objects, and you touch it and you get it on your hands, the way you get infected is not that the virus now sort of dissolves into your hands and through your skin. It's often is that we put our hands to our mouth and our nose and we scratch them, and we do it countless times unbeknownst to ourselves. And hopefully by having a mask, if you're sort of in the habit of reaching out and scratching your nose or scratching your mouth, you have at least a barrier to prevent that. The second issue is social distancing, keeping at least 1 meter, if not more, apart from each other. In the United States, we say 6 feet, which is about 1.8 meters. So the further you are, the better. But at a minimum, you need to be at least 3.2, 3.3 feet to stave off the likelihood of getting these larger respiratory particles, which is with the majority of the way the virus transmits. And the last thing is to minimize what people describe as the 3 C's, not in terms of sort of diamonds, but sort of in terms of infection. And this 3 C's are avoiding trying to be in closed environments, being in very crowded environments, and when you're having conversation, being close to individuals to have that conversation, just like that picture on the right describes. Try to do things outside if possible. As I mentioned earlier, UV, heat, humidity, all sort of help reduce the half-life of these viruses, and to also minimize your exposure by planning sort of your trips out of the house and lumping things together. Going to Costco to get a watermelon and then going back the next day to get paper towels may not be the best sort of best strategy with regard to minimizing exposure. Lumping sort of these trips out so you minimize the amount of time you're really exposed to folks who might be asymptomatically infected. And then lastly, what's out there from a health therapy standpoint that we can rely on to minimize this? Since this COVID started 7 months or so ago, we've learned a lot, and vaccines are really on the cusp of being a reality. Just to give you some context, it takes on average about 10 years to develop a vaccine against an infectious agent. We still don't have a vaccine for HIV for that matter. And there are a number of other things like dengue, fever that we don't have vaccines on. And so to go from nothing to potentially having a vaccine available in a year is literally warp speed. And we'll keep our fingers crossed. There's about 155 different vaccine programs in development now. You can sort of see where they are in the phases of this. And so we'll have to see how things are moving toward these 3 different phases and getting to the point where it will be approved for the general use as opposed to limited use. There are no proven therapies to prevent infection if you get exposed. So there aren't any prophylaxis agents, but there are a number of things that have been proven to treat COVID in some form or fashion. You may have heard of remdesivir, which doesn't have any mortality benefit, but cuts the recovery time by about 4 days if you're treated with this. Dexamethasone is a steroid that actually, for those who are really severely ill from COVID, can actually see a mortality benefit anywhere between 20 to 35%. Enoxaparin is a blood thinner. One of the complications of COVID is to develop blood clots, and taking a blood thinner actually significantly improves some of these patient outcomes. And then we're also sort of appreciating that when people have shortness of breath or have breathing problems, putting them on a mechanical ventilator doesn't necessarily is not a guaranteed thing. Proning people, putting them on their belly and breathing in that fashion has also been shown to be very effective in reducing the likelihood of needing to be on the ventilator. And there's a number and a host of other different things. Lastly, there's been a lot of conversation, a lot of witch's brew things that really are important to stress to folks that this is not the right thing to do. People have started to sell elixirs with silver in it. No benefit there. In fact, there might be harm. People have tried to use UV light to shine their eyes and shine their face and shine their skin to try to kill the virus. That doesn't work. And then more importantly, people have actually started using bleach to try to kill off the virus by drinking it, putting it in their foods, things of that sort. In fact, after some of our government leaders talked about possibly using bleach as a household cleaner, about 20% of folks in the US actually started using this. And so it's a real serious concern to make sure that we're not propagating falsehoods and false claims about how some of these agents can actually kill the virus when they certainly can't and actually can do more harm. So with that, I'll end here just to give you a quick timeline and how quickly things have developed over time. The pandemic was declared on March 11th. And since then, we've really ratcheted up over the subsequent 3 months, a lot of information about this COVID, and the story continues to evolve. So stay tuned and talk to your doctor if you have any questions with regard to this, because it's a rapidly moving environment. So with that, I'll end there. Thanks, Lopa.
Thank you so much, Alan. That was really wonderful presentation. And there are two, three questions. So what we have decided as a team is that we will probably take the questions at the end so that you hear all our speakers and maybe your questions will be answered eventually, as our speakers speak through. And that was wonderful, giving an overall insight about the full COVID scenario. I'm sure it was very helpful for all of us. It was very helpful for me too. And so, Alan, if you would kindly give me the host rights so that I can, move to the next speaker, that would be great. Thank you so much, Alan, for the wonderful talk.
Hey, Lopa, how do I give you the host? Because I just stopped sharing my screen.
If you right click on my button on my link actually. So
okay, got it.
Yeah, that would be good. Yes, I'm the host taking now. Give me 1 second. Let me just turn on the. I don't want to be. Okay. So our next guest is Dr. Ben Park, and I will just give a little introduction. And thank you so much, Dr. Park, for your time today. And I know you both are super busy, Dr. Allen, Dr. Park, and still giving us time. We are sincerely grateful to you. So a brief introduction about Dr. Park. Dr. Park did his MD PhD from University of Pennsylvania School of Medicine. He also was at the Sydney Kimmel Comprehensive Cancer Care at Johns Hopkins and was the Professor of Oncology, Associate Director of Education and Research Training, and Associate Dean of Postdoctoral Affairs for the School of Medicine prior to joining Vanderbilt University Medical Center in 2018. And so since 2018, he's now the Donna S. Hall Chair in Breast Cancer, Professor of Medicine at Vanderbilt University Medical Center. He's the co-leader Breast Cancer Research Program. He's the Associate Director for Translational Research, Director of Precision Oncology at Vanderbilt-Ingram Cancer Center, and he's also the Interim Director of the Division of Hematology and Oncology. It's an honor to have Dr. Park here to hear his perspectives on the COVID-19 scenario with the cancer patients or the cancer survivors. So thank you so much, Dr. Park. And I would request Sandeep to please make Dr. Park the host so that he can share the screen if he would need.
Thanks so much, Lopa. I'm just waiting to be the host. All right.
Okay. And I would request everyone to please mute yourself when our speaker is giving his presentation. That would really help all of us. Thank you so much.
Can you all see my screen?
Yes, we can, Dr. Park.
Awesome. Let me just get this out of the way. Oops. Sorry. Well, thank you for the gracious introduction, Lopa, and thank you all joining us and having me give a few thoughts about what's going on with COVID-19 and breast cancer. And even though I put breast cancer in this talk, this probably is applicable to many solid tumor types, may not be as applicable to what we call hematologic malignancies or liquid cancers, and those would be things like leukemias. And that will become a little bit more apparent why that is in the talk. And I've purposely kept this short, one, because I would really welcome a discussion, and two, Dr. Cheng did a great job giving background on what the state of the art in terms of therapy and our knowledges of spread and incidence and what we can do to mitigate that. But two, I'd really like to emphasize not only the conversational aspect of this, but the fact that we just don't really know that much. We know a lot more, as Dr. Cheng said, before March, but for sure there's still a lot we don't know. And I think that's going to be my tale of one of maybe measured optimism, but also caution that we seem to learn and change guidelines as we go along. And I will try to put some examples of that, even though they may not specifically be in these slides. So what do we know? Well, one of the things that has been really daunting with this virus is that it has a long incubation period, and Dr. Cheng may have mentioned this as well. But when you think about what viruses traditionally have done, you get infected, you have symptoms, and we can identify those patients fairly rapidly. This really turns that on its ear and has made it that much more difficult, because initially, before we had enough testing, and there are still some countries that probably do not have adequate testing, a patient may be infected for 2 weeks and maybe possibly more before they actually develop any symptoms. So that patient during that incubation period has now the capacity, as we saw in Dr. Cheng's slide, to really infect a lot of other people. And that's really a huge problem that is, I won't say unique to COVID-19, but certainly is a little bit more prominent than we've seen with other types of viral pandemics. The other thing that we also know from that's really taxing our healthcare systems, particularly now in the South of the United States, is that patients who do get really sick and then get on a ventilator, a breathing machine, they tend to stay, at least in the hospitals that we've been looking at, including our own, on the breathing machine, being intubated for weeks. So that's a little bit unusual. When we see patients who are on ventilators for weeks, one, they usually don't have a great prognosis, meaning that many of them don't get off the breathing machine, particularly those with cancer. But this one's a little bit different. These are previously healthy individuals, get an infection, have a very bad symptomatic outcome, and get on these machines, but they can come off. But initially, that's where our concern was, do we have enough ventilators or breathing machines for all the patients that are going to need them? And even though initially many parts of the country seem to be okay, we've seen what happened in New York where they didn't have it. This is now happening in other southern states such as Texas, where there's really an upsurge. And colleagues down there have told me they are running out of ventilators. So that also makes this very, very challenging. As Dr. Cheng also mentioned, we know that cancer patients are at increased risk for worse symptoms. We're not 100% sure why, but I think this is one of those areas where logic would dictate, since many of the things that we give our patients for therapies and treatments are in fact immunosuppressive. And so that probably allows what could be a natural immune system to fight viruses and other infections to be somewhat decreased, for lack of a better term, or what we sometimes call neutropenic or lymphopenic, meaning that their immune cells are actually decreased because of the therapies that we give them. And we know that for some cancers, such as liquid cancers, as I mentioned earlier, that's a disease of blood cells. And of course, white blood cells are our immune system. And so having a disease of blood cells will actually also make you immunosuppressed almost by definition. So if you put all those facts together, the therapy, the intrinsic natures of cancer, that is probably the likely reason why certain cancer patients are really at increased risk. We also think that perhaps for some cancers like lung cancers, where we've seen a lot of increased deaths or mortality rates, that perhaps being in vessels or an area that's highly aerated and has a lot of blood vasculature may also lead to worsening symptoms for reasons that aren't completely understood, but we heard about things about clotting, for example. In an autopsy series, it looks like there tends to be a lot of clots in patients. And in lung cancer patients, it's already, and many solid tumors, already an increased state of hypercoagulopathy or hyperclotting. And so again, some of those may factor into this as well. As we heard from Dr. Cheng, A limited but number of medicines that have been studied do show some effectiveness in probably reducing the time, for example, on hospitalizations, et cetera. But there's still a lot we don't know. There are, of course, the early studies, many of which were now retracted. So we have a problem here that in our efforts as a medical field to get as much data as possible, some of the, I think, more rigorous methodologies of how we do clinical research have been, I won't say bypassed, but probably not as rigorously adhered to. And I'm not trying to knock that and say that that's not something, you know, that was a bad thing. I think we all need to try to get as much information as we possibly can. But at the same time, because this is so new, as I said earlier, that's one of the reasons why I think we're still dealing with a lot of unknown. I do think, and again, Dr. Cheng mentioned this, we do know masking and social distancing do work. That's pretty unequivocal at this point. And so these are the things that we're trying to do in our society, but especially in our healthcare systems to really make this not as widespread and not as lethal. So what we don't know is pretty much everything else. And I put that up there because we tend to, right now, look at the data that we have and then try to put policies in place as quick as possible. I will tell you, for many of us, this has not been a easy thing. I'll give examples that we've seen in our own medical center, initially because we were short on personal protective gear, things like masks. We didn't actually mandate masks at our hospital initially. Unless you were actually taking care of a COVID positive patient, this was something that was felt not to have evidence. Now, I will put out there, we didn't have evidence one way or the other. And I actually had to make a special request that because what was happening with cancer patients and the data that was emerging, that at least for cancer patients, we should be wearing masks all the time. But pretty much we didn't have enough masks at that time. Once we had enough masks, we pretty much mandated masking for everyone in the hospital, both coming in, whether you're symptomatic or not, as well as all healthcare providers, whether they're taking care of known COVID positive patients or not. So that is something that, again, was an incremental uptick, but was really based upon limitations of personal protective gear. Along those lines, just this week, our medical center, now that we know that there could be aerosolized forms, that this could also go into, we believe, maybe through our eyes, rather than just masking, we have now mandated that our healthcare providers who are seeing patients should actually wear goggles and or face shields. And that is brand new for us, and probably something that has also already been in place at other places or other parts of the country and the world, or not, and may in fact we'll see an uptick of that. But again, we're just like we were before with masks, we're somewhat limited right now in our protective eye gear or face shields. And so this is something that we don't really have hard evidence on, but this is something that our leadership here felt that we should try to implement as soon as possible. And I think that lack of evidence has also led to a lot of confusion. And in some cases, I would say in the public, complacency. And that with kind of what I would call fatigue of staying home and socially distanced has led to people, particularly young people, going to bars, going to restaurants, going to those hot zones that you saw Dr. Cheng show in his graphs, how people are actually super infectors. And this subsequently has led to, several weeks later, this huge uptick in the South. So this is, again, lessons learned. We have to be vigilant and non-complacent. So how does this affect cancer treatments? And again, I'm using breast cancer as an example, but really almost any type of solid tumor we can really think about. What we and other academic medical centers have done in the beginning was really try to minimize patient contact and try to prioritize therapies. So what do I mean by that? Well, probably many of you now know that, at least in this country and probably other parts of the world, telemedicine or telehealth has become a very big thing. And so beyond using Zoom for our conferences like we're doing today, we're also using Zoom in a patient-compliant way or HIPAA-compliant way. We're also using that to actually visit patients virtually, if you will. It's surprising how much can be done online, and this is something that Vanderbilt University Medical Center was doing even before COVID, was moving towards a virtual health option so that we could reach more patients and make it convenient. There are even things, believe it or not, where you can do the physical exam at home by using Bluetooth-enabled equipment, such as stethoscopes and other types of gear that allows the physician to see in real time on the screen what the readout is. And dermatologists here, for example, have had patients either take a picture of some sort of skin lesion or use it right on the camera. It is not a perfect substitute. Nobody really believes that. But at the same time, in many ways, it's become a modern house call visit. This has been a little bit stymied because of the way the United States at least uses medical licenses and restrictions. It's done at the state level. There's a movement, I hope at least, that we will try to, at least going forward, make those requirements a little bit more relaxed. They certainly have during this COVID for some states, but not for all states. And I think as we keep showing the projections that this is going to be with us for probably the better part of at least through December and probably through the early part of next year, that we will have the capacity to take care of our patients who are across state lines. So this is challenging from not only a biologic and therapy type of venue, but also even from a political one in terms of how states are regulating medical licenses in this country. But what we've tried to do in the interim is prioritize therapies. And what do I mean by that? Well, if you take a scenario that I just had back in March, I saw a patient who had breast cancer that was what we call hormone receptor positive, HER2 negative. And I may have actually, and my colleagues here, recommended a surgery first approach. That would be pretty standard. However, we do know that giving what we call endocrine therapy first or neoadjuvantly is an acceptable option. It is part of our guidelines for certain patients. And so I talked with the patient and as well as the surgeon, and we made the decision, since she could just take a pill at home every day, that's endocrine therapy, that would probably be safer for her to do that for several weeks to months. Obviously, we would still follow her exam every few weeks, but then make the decision at some point to do surgery when we could. And I think that strategy has been borne out across a lot of the academic and just cancer centers in general across the United States, to really start thinking about, if you have a solid tumor patient, what makes most sense, as long as care is not compromised, what makes most sense to do first versus last. And I think that that's really become the theme of what has emerged during this COVID epidemic, is try to use common sense and think about what puts the patient at least risk. Obviously, there are some situations where chemotherapies have to be given. And in those cases, we really think hard about, can we alter the scheduling? Can we make it more convenient for the patient in terms of not being able to have to come in as frequently? Another example of that, and some of you with breast cancer know these, that if we give a chemotherapy regimen that has weekly Taxol, so that's a chemotherapy, we could also give that just as effectively likely as every 2 weeks with a higher dose, or even every 3 weeks. Similarly, if we have certain types of chemotherapies that we know the likelihood of the white blood counts are getting really, really low, we actually will do prophylactic or pre-therapy testing. And that's also something that has now emerged as we've gotten more tests online. You have to remember, at the very beginning, that was another limiting factor in trying to understand and protect our patients and healthcare providers, is that we didn't have enough tests. Now we do, and so patients who are getting elective surgeries, getting elective chemotherapies and certain regimens and other therapies that we give to cancer patients, we are now pre-testing those patients to make sure that they're not COVID positive. The tougher question became, obviously, what if they are COVID positive and asymptomatic? And so really, we're taking those right now on a case-by-case basis with discussions with other healthcare providers as well as the patients themselves. Another question that has come up is, what about immunotherapies? I think many of you on this call recognize that immunotherapies for cancers have really revolutionized the outcomes of certain diseases like melanoma and renal cancers and perhaps some lung cancer subtypes. The thing about immunotherapies that one has to remember, these immunotherapies essentially turn our immune systems against our cancer. And so in theory, they're revving up the immune system. So why would we be concerned if we have a virus in a patient where we give a therapy that revs up the immune system? Well, that's actually not the primary reason we're very cautious about giving immunotherapies. It's the fact that immunotherapies, even though on a small subset of patients, relatively speaking, they can be very effective, on many patients, they have very severe side effects, including death. And so what is our natural kind of mode is that when we give an immunotherapy, we assess for symptoms, for autoimmune symptoms. And sometimes, many times actually, we have to give immunosuppressive therapies to abate those symptoms, to make sure that the immunotherapy we just gave a cancer patient doesn't kill the patient from side effects. Now we're on the other side. If we're going to give an immunosuppressive therapy and that patient is COVID positive, are we now weakening the immune system to the point we're going to do more harm than good? And that's a real hard seesaw, if you will, to balance. And that's why we've really thought long and hard about making sure that these patients also get tested and weighing the risk benefits. You know, it's one thing if a patient is on their last line of therapy and there's really no other options and they're going to pass away from their disease. It's another thing if they're really already healthy and this is something that we're not sure is going to have huge or tremendous benefit or value. So those are, again, the questions that we're grappling with, and we don't have clear-cut answers. Again, common sense is prevailing here, and we're trying to do the best we can on an individualized level with what little information we have. This is another question that we've been getting asked a lot during the COVID pandemic about cancer survivors. And again, I'm using breast cancer as an example, but really this could be any cancer, solid tumor type of patient. The key point right now is that there is no evidence that once all therapies are completed and patients are fully recovered, that there really is any increased risk. Now, by this, I mean these are usually early stage patients who have gone through surgery, any chemotherapies if they needed, any other additional therapies, radiation, etc. And these may be patients who had their cancer 5 years ago. We don't feel or think necessarily that they're at increased risk. Again, there's no evidence that that is the case as of yet. But I also want to caution, just as I said earlier on, there's no evidence one way or the other. This has not been studied enough in a longitudinal fashion. And we know that for certain types of cancers, including breast cancer, there can be long-term disease-free intervals before patients relapse with, let's say, metastatic disease. That's something where the data just aren't there yet, and it probably won't be there yet for years, maybe even decades in some cases. So I put up these notes not as complete facts, just want to be very, very honest and upfront about that. This is based upon what we currently know today, but it is by no means definitive until we have more data. On the other hand, some patients, and those are patients either with early stage, as I was mentioning earlier, who are getting all their standard of cares, including sometimes immunosuppressive therapies, and then certainly patients with metastatic disease. And in metastatic breast cancer, many of you know this already, that some patients with metastatic disease are on therapies for years, if not decades. Now, depending on what those therapies are, whether they're endocrine therapies or chemotherapies or other types of immunosuppressive therapies, they may be at increased risk. And those were some of the patients that I was mentioning earlier that we were doing testing, or now we're doing testing since we have more tests preemptively to see whether or not they are. Again, there are caveats with this. We don't really know, how good testing is from one site to the other. In an effort to get testing out there, as I said earlier, some of our more rigorous metrics were a little bit lax. And so there's already data that there is a rate of false negatives and probably false positives as well, meaning that some patients probably are falsely diagnosed with COVID. That probably is not as high as the false negatives. Those are patients who are in fact COVID positive, but for the tests, we don't actually have a positive test that demonstrates that. And some people have really advocated and in certain cases mandated serial testing or repeat testing to make sure that you have to have multiple negative tests to really be considered COVID negative. This is particularly in patients who are symptomatic and show really signs of things that might be associated with COVID. All right, so the effect on research has also not been, without complications and certainly without damage, so to speak. Clinical trials are a big portion of what academic health centers do. Whoops, sorry about that. And Vanderbilt is no exception. At the beginning of this, out of an abundance of caution, pretty much we shut down all clinical research, including breast cancer clinical trials. And this was pretty uniform across the country with probably a few notable exceptions. As you can imagine, that really hampered our ability to take care of patients on those clinical trials, meaning that many of the patients that were getting queued up to be on there, we had to stop. And so they were offered different standards of care. Patients who were already on clinical trials, for the most part, were allowed to continue because we felt that we had to. But this is something that, again, we had to come together quickly as leadership and make policies to do what was best for the patients. Without knowledge, again, an overabundance of caution was that we shut things down. We started reopening up here probably in the late part of May in a very small graded fashion. And then we're pretty much fully open right now in terms of clinical trials. Again, what has been different now is having increased testing, so we can test all patients coming in, getting on these trials. We also have masks for everyone. And now at some point, we'll probably also have eye gear and face shields. Again, we don't have the best data about the latter yet on face shields, but it's felt to be that probably this is the right thing to do. And I think that this is one of the areas where being overly cautious probably has little downside, whereas being not as cautious probably could have some significant downside. One of my colleagues was joking to me, said, you know, why don't we just all put on hazmats outfits from head to toe? And honestly, probably if we had enough of those, we might do something like that. But for right now, we're trying to actually contain this as much as we possibly can and still maintain some semblance of normalcy. Laboratory research, on the other hand, has been really slow to reopen. And again, it's kind of been in a measured fashion. Part of this is that we're trying to protect as many people as possible. We're trying to prevent infection. There was a lot of slow responses, I think, where people didn't realize that, you know, why should we shut down laboratory research? They're not necessarily directly involved with patient contact. You know, many lab people are trainees who are students and postdocs, and they're fairly young, so the risk of dying is very slow. I think what we had to message to our colleagues was that, yes, that's true, but at the same time, you know, if you have a young person who gets sick, maybe is even asymptomatic, that person could be one of those super spreaders and go to a bar or, you know, God forbid, you know, go to a crowded area or beach and start infecting even people who are at increased risk from getting the infection and having horrible symptoms and dying. So things were shut down. Again, it took a while to get faculty to shut down completely because of the nature of lab research. We had to, you know, freeze down a lot of cell lines, had to make sure that we had someone taking care of mice, laboratory animals, but we are now slowly reopening, particularly with our university counterparts here. All of our students are on the university side, have a much more measured or graded fashion of reopening. Like it or not, this has had a, I won't say necessarily chilling, but certainly debilitating effect on laboratory research. Many of us have not been able to carry out the research that we had hoped to. This has stymied a lot of research in a different way, where philanthropic foundations have not been able to get donors to the point where certain grants cycles were actually just dissipated and closed. So how this will look is not going to be felt, I think, for another probably couple of years. But this is something that I think everyone should be aware of, that COVID has really hurt the mission for cancer research in a number of ways. And so what can we do? I think we already discussed, and Dr. Cheng again showed very nicely, masking and social distancing are kind of social responsibilities for everyone. We need to really make sure that we're doing all we can to mitigate the spread of this virus. I think if you're a cancer patient, whether you're undergoing active therapy, new diagnosis, or a survivor, talk to your care providers, understand what they are doing to mitigate risk. I mentioned some of those on there, but telemedicine is still, I think, a viable option for a lot of what we do, and will really protect patients from getting exposures when they don't need to. And I think above all, using common sense. This is where, you know, in the absence of data, we have to do things that make sense, and again, using an overabundance of caution, not take risks that are unnecessary. This is something that I think is hard for a lot of the public to accept when we've all been cooped up for weeks to months on end, but it's not going to get better. And as we heard, vaccines are still a ways away. So I think we need to really do what we can to minimize the damage. And if you get nothing else from this talk, I would implore you to just use common sense. And I thank you for your time.
Thank you so much, Dr. Park. That was so insightful for all of us, and really, really helpful. And we have few questions probably we'll take at the end once we go over the other speakers. And thank you for your, you know, I'm so happy and impressed that everyone muted this time. And really thank you for respecting our speakers for that. Thank you, Dr. Park. And now our next speaker is an amazing friend of mine and an amazing woman, actually. And I call her Captain Evie Cormican. So she flies, Captain Evie Cormican flies Boeing 757, 767 for a major US airline. Her previous roles include Assistant Chief Pilot, the Flight Operations Representative for the HIMS Base Monitoring Committee, MX Liaison, and the IAH Chief Pilot Office Community Affairs Representative. B756 instructor or evaluator responsible for initial and continuing qualification pilot training. And also with flight manual writing and editing to align and ensure standardized international procedures across all fleets. And now she is also the CEO of Visionary Training Resources. She is a TED Talk speaker. And I know Evie because we are from the same MBA, not the same program, but we went to the same school for our MBA at Northwestern Kellogg School of Management. And the reason why Evie is here today, because she is a cancer and COVID survivor. So thank you, Evie, for your time today, and over to you.
Thank you so much, Lopa. Thank you, Dr. Park and Dr. Cheng. I don't have a PowerPoint. Basically, I'm going to talk about COVID coming into our household, and it's an experiential talk about basically the whole family getting it. As you heard, my husband and I are both airline pilots, and on March 10th, he flew a 3-day trip with 2 overnights in New York City. And when he came back and returned to Denver, we thought he was just tired from the trip, which is sometimes common. But I'm going to read his symptoms and his days for you. Remember, this is just 2 data points and how we handled it as a family, basically. Our children are 21, 19, and 14. I had breast cancer 4 years ago. So although I thought I was the one immunosuppressed, you'll see that his symptoms were much worse. As I've seen in males over the age of 50 seem to get hit pretty hard. So on day 1 is March 17th. Of course, he flew the day before they declared it a pandemic, as Dr. Cheng talked about. Body aches, particularly in knees, hips, and neck. He said basically he felt like he had gotten into a bar fight, which is atypical for him. Mild fever, he had about 101. Day 2, extremely fatigued, bedridden. Fever was up and down all day, but no higher than 101 sunken eyes. On day 2, we decided to quarantine him. Day 2 is also, I don't know if you guys are familiar with Chris Como, but he did a live daily update of his COVID. And on day 2, I had watched that the virus doesn't like hot, humid, and high temperatures. So the 4 of us, the rest of the family, were get into a little bathroom and do a steam shower. Now we did 2 steam showers a day for the next few days. Day 3, slept all day, sunken eyes, extreme body aches, mild swelling of the glands, particularly on the left side, max temperature 103.2 degrees. Day 4, woke at 7 a.m. feeling relatively good, appetite for the first time in days, ate soup, had lots of tea. In the evening, left side of the neck was very sore, not like a sore throat, more like muscular or stiff neck, and fever still at 103. Day 5, sore neck is gone, but is definitely now in the chest. Deep breaths are noticeably difficult and cause coughing attacks. Much less energy than day 4, no appetite, runny nose, noticeable fever. Tried to get an appointment with a doctor, but was unable. On day 5 is when I contracted. I'm going to keep going with his days. Day 6, woke with more energy and an appetite, very mild dry cough, nasal drying up, no noticeable fever. At the advice of the doctor, bought a pulse oximeter, and it's at 91%. Cough subsiding, 0 sense of smell and taste. Day 9, much more coughing, sometimes feels to be loosening in the lungs, O2 level down to 90%. Night of the 9th, shooting pains in the chest, particularly left side. Sorry, it's hard to read. Feels like someone is standing on my chest. Inside the left lung feels like it's turning to glass and cutting me up. Very restless night. Woke several times in the night and feeling that my chest was in vice, being tightened. O2 level 89%. Considered going to the ER. Still no smell or taste. Day 10th, we finally got in to see the doctor. Left side, we didn't get in, it was a video. Left side of chest still has sharp pains. Difficulty raising arm due to pain. Pressure on chest seems to have subsided somewhat. Still have pain on the left side when taking deep breaths. O2 is up to 94. Taking Mucinex DM at 12 and 9, a Z-Pack at 4, inhaler at 5 and 9. By 9, pains in the left lung are not as sharp, but much more frequent. Day 11, woke up several times in the night feeling suffocated, like an elephant sitting on my chest. Woke in the morning with sharp pains on the chest, but a definite tenderness. But O2 is up and steady at 94. Slept very well. Day 12. No elephant on the chest. Deep breathing exercises. Bring on a cough, but don't hurt. Very dull, infrequent pain in chest. O2 still at 94. Day 13. Feeling pretty good. Mild dry cough, no chest pain. O2's at 95. Still no sense of smell or taste. Day 14, feeling good, no pain, mild dry cough. O2's at 95. Day 15, felt good all day, no pain, very little cough. At 11 p.m. had a coughing attack. Kept me from sleeping, but got up at 12:40 and took Mucinex DM and hot tea. Took an hour for the coughing to stop. Day 16, coughing attacks on and off. Cough isn't as dry as it was before, but something is loosening up in the lungs. This went on till day 21. He still has a low sense of smell. He is healthy, he survived. I like to say that Chris Como saved our life because he said the most important thing was to get up, walk around when you don't feel like it, and lay on your stomach and don't lay in bed. And that was really, really helpful. Now, on his day 5 is my day 1 on March 21st. Severe body aches and headache. I hardly ever get headaches. Even though I had body aches, on that day, we moved our son out of college for COVID. But overnight, I had severe body pain and took another steam shower. Day 2, unable to get out of bed. Hot sweats, temperature of 103, but got up and did a steam shower. Day 3, still in bed. My fever is down to 101. I still have body aches, sinus headache, runny nose. The steam showers just brought me relief. Day 4, on March 23rd, out of bed, very low energy. I decided to take a shower that day, but I almost passed out. Starting to feel pressure in the lungs and beginning of a cough. Day 5, mostly in bed, dry cough, but productive. My body aches are gone and I'm starving, but I lost my sense of smell and taste. Day 6, much better today, energy coming back, occasional cough, lost sense of smell and taste. Now I'm taking care of sick kids and my husband. Day 7, sense of smell and taste still gone, occasional cough, all other symptoms are gone. Kids are recovering fast. I think it was my chicken soup. On day 14, I finally smelled my coffee in the morning. So what I want to say is, like, as the doctor was saying, even though we've had cancer, we might not be the most immunosuppressed people around. And you don't know. My husband is very healthy. He's very active, but it hit him really, really hard. And we practice social distancing and wear masks anywhere we go. We try and only go out once a week. And I feel like that's the best advice that you could give to everybody. Thank you. Thank you, Lopa, for the opportunity. I'm sorry I got so emotional.
No, thank you, Evie. I mean, it's difficult, and I mean, really hats off to you for being able to share your journey. And I mean, I really don't know what to say, because it's not easy to come up here and give your timeline, the data about your family, and sharing this experience. You had everything that one can get with COVID, and you came out of it, and you are a winner, and you are always a winner, and you will be always a winner all throughout your life. We love you, Evie, and thank you so much.
Thank you. I hope that this helps people understand that, hey, it's not the end of the world. You can get through this. You can survive this. But not getting it, that's the best option.
Yes, absolutely. Thank you so much, Evie. And I'm seeing a lot of questions coming in. As I said earlier, we will definitely take all your questions at the end. And Evie, you know, I'm seeing a lot of messages, and everyone is, you know, with you, and they all are pouring in with their messages. We all love you. Our next speaker, okay, so we all want to, I can see Shalini clapping for Evie, so yes. Thank you everyone for the support, and so blessed to have all our esteemed speakers and amazing people they are. Our next speaker is Laura A. Franklin, and we connected through LinkedIn. Laura reached out through LinkedIn, and we had a discussion, and then I thought about this scenario, and that's when I thought about Laura. And thank you so much, Laura, for your time today. She is a two-time breast cancer survivor, an advocate, public speaker with a demonstrated history of working in the human services industry. An amazing woman when I spoke to her the first time, and you will see why I'm saying that. Over to you, Laura. Thank you so much for your time.
Thank you, Lopa. Good morning, everyone. As Lopa said, I am a two-time breast cancer survivor. And one of the things that we have been doing as a family in COVID, because my first diagnosis was 2001 and my second diagnosis was 2006. So though I've been a survivor for 14 years almost, I still take precautions for my health. So I don't go out unless I have to work. And when I work, we are in separate offices, which really helps. And we wear our masks in the office as well as the gloves, and we wipe down everywhere. And when I go out to the grocery stores, I wipe down the cart, I wear my mask. I don't really talk to a lot of people in the store because I want to keep the distance. And when I'm home, I wipe down. And most recently, we just had a COVID scare where I came in contact with someone who had been in contact with a positive COVID tester. So I had to take off work for about 4 or 5 days to self-quarantine and be tested until I got my results. And so even no one was allowed to come over, no packages, nothing. All my mail just stayed outside because I just wasn't sure. And so, but my test did come back negative, thankfully. And even when my kids visit now, we wear masks in the house because they are working as well. So they're considered essential workers. So we no hugs, no handshakes, none of that, even though I miss them from them, but I have to make sure that they're safe as well as myself. And when I go through my home, I also wipe down doorknobs. I was lucky to find a can of Lysol and spray down my doorknobs as I go. And just wiping down, just making sure that I take all the precautions necessary. And it's been a challenge because I'm a people person, I'm a hugger, but I do understand the brevity of what we're dealing with right now. And I'm really thankful to Dr. Park and Dr. Cheng for what they shared, because some of that information I did not know. And so I'll share that as well with some of my family members and my friends. So, but just grateful to be part of this panel, and thank you, Lopa.
Thank you so much, Laura. That was so helpful because, wearing mask inside the house and, doing all that on the daily basis, because you are going out every day for work, and even your kids too. So that is really wonderful. Thank you so much for today. And our next speaker is John Marmando, who is a Senior Vice President at Argeo Brienne Energy Futures. And he is a breast cancer and COVID survivor. But before I request John to speak, I also want to give a big shout out to Male Breast Cancer Coalition, because and Peggy and Cherry are here. So for Breast Cancer in Men, Breast Cancer Hub, we collaborate with Male Breast Cancer Coalition, and because of Peggy and Cherry, I'm introduced to John today. So John, thank you so much for being here. I know you all are busy with your work, but still you took time to share your journey, which itself is a big step for someone to come out here and speak about your story. Thank you so much, John, and over to you.
Hello, everyone. I have this rare distinction of being a breast cancer survivor and also a COVID survivor. So I don't know if that makes me lucky or unlucky, but I'll say lucky because I got through them both. So. Yeah, in 2018, I felt a lump on my chest. It turned out to be breast cancer. Later found out that it was a 9/11 related. I am a commodities broker, and I was trading in the financial center in New York. And we went to work 6 days after the towers came down, and went to work every day in that toxic environment with buildings burning and everything else, as you all know. And 18 years later, it turns out that a lot of my friends were getting cancers and different types of respiratory issues. And so it turns out that I did get a 9/11 related breast cancer. I think my being in pretty decent shape helped me get through that. I'm an endurance athlete. I do marathons. I do long distance triathlons. So that helped me get through the cancer. I went pretty well, I should say. I mean, I had my side effects, but I got through it. Fast forward 2 years later, in March of this year, March 5th to be exact, I got my first symptom of COVID. And I believe that I contacted it from a friend at the bowling alley who went to the bowling alley that night not feeling well. And of course, that was March 1st. So this is before the coronavirus was a thing. This was, considered a Chinese virus that was only in China, really. So anybody in the States that was getting sick, obviously we just thought it was the flu. And that's what we thought. And that's what he thought. He thought maybe he was just coming down with a mild sickness, a mild cold. And he decided to go to the bowling alley and bowl anyway, because he was the president of the league. So he had a lot of responsibility. And I saw him there that night and said hello, shook his hand. We talked, we chatted for a while. 2 days later, he was very sick. And 4 days after I had first saw him, 2 days after he was sick, I was sick. So I assume this is where I got it from. That's the only link I could think of. The weird part about, and the doctors could chime in on this later, is we talk about this incubation period and not knowing whether or not we're contagious or whatever. Now, I saw him on March 1st, which was a Sunday night. Monday, I got up, went to work. I was obviously Sunday night, came back home, slept in the same bed with my wife, saw my son. Monday, I go to work on the train. I take 2 trains to the city every day to Times Square. I sit with a bunch of guys that were, the train buddy friends. We sit together every day. Took 2 trains into New York City, through Penn Station, into work. I have 2 partners that sit in a trading desk, pretty close proximity. I did this for 4 days and nobody got sick. So that's the kind of quirky, kind of weird stuff that you read about this COVID, is because there's really no, definite answers on how people are contagious or what. I mean, that was 4 days of me sleeping with my wife in the same bed, seeing my son every day, being around coworkers and on the train. And not only that, but 2 days after I had seen my friend at the bowling, I also bowl on Tuesdays, 5-man team, 10 people on a lane, shaking hands, high five, not one person got sick. So very, very odd. Now, when I did get my first symptom, it was a Thursday night, and I was sitting on a couch with my wife. We were talking, and I got a chill. So immediately I went to go check my temperature, because I already had known he gave me something. I checked my temperature. I had 101 fever. Immediately, and this is the important thing, immediately, my wife quarantined me down to the family room. And basically just because, and we didn't think coronavirus or COVID or anything like that at this time. She just didn't want to get sick. So she's like, okay, you're going to sleep down the family room. And I did. I went down to the family room, and the next day I was getting sicker, and we went to the hospital. And only because my friend was texting with me and saying, John, I'm really sick. I'm really sick. If you're sick, it's going to get worse. So I, in the back of my mind, my wife and I were like, okay, we got to get this checked. We went to a hospital and went to the ER, masks and gloves, the whole thing, because I didn't know what it was at the time. And the doctors there basically discounted it as just a flu. They weren't going to give me a COVID test because I didn't fit their parameters of I wasn't in China, I wasn't traveling in Europe. So they just said, you probably just got a bad cold, maybe a flu. They did give me all the flu, I got all the swabs. They did give me all the tests. Everything comes back negative. And after listening to my chest, he says, yeah, you might, it looks like you got sick. Just, quarantine yourself. But they would not give me the COVID test. I think mostly because they didn't have a lot at that time. This was March 6th. And they were only specifically keeping it for people who were, like I said, coming back from China or traveling abroad. So a couple of days go by, I'm getting worse and worse and worse. My wife says, finally, we need to go to a different hospital. So we go to our little local hospital down here, and they did give me the test. They did a chest scan because my chest started feeling really bad. Comes back, full pneumonia. So at this point, the guy says, okay, you're feverish, you're coughing, you're having difficulty breathing, and now you have pneumonia. We're admitting you. So that's when I got admitted. I stayed in the hospital for a full week. And I was, don't forget, this is way before all the so-called remedies going around now with steroids and remdesivir and hydrochloroquine. There was nothing. So my whole regimen every day was, I was on intravenous fluids because I was getting dehydrated. But the only thing that I took every day was Tylenol to help me with my fevers, because they were spiking every day, like to 103. And I was taking a cough suppressant with codeine because the cough was incessant. I mean, it was constant. So that was it for 7 days. That's really all I got. They gave me a albuterol treatment one day because I was coughing so bad. Turned out to be the worst thing I could have done. That night, my heart rate got so high because of the stimulant and albuterol. I was laying in bed with a heart rate of over 120. It was like, and I'm a runner, so I know what your heart rate should be when you're running. I should not have a sitting heart rate at 120. It was ridiculous. My breathing was way off. I was coughing crazy. I had 102.5 fever. It was the worst night I had in almost the 2 weeks that I had been sick. So my nurse called in what they called a respiratory team. And about 5 or 6 nurses came in, and they were judging on what I was doing. And I heard this one gentleman tell my nurse, I think we should take him to ICU and put him on a ventilator. And I just went, no way. I was screaming, no way am I going on a ventilator, no way. And now this is before we know that ventilators were hurting a lot of people. We know that, right? But this was before that. The only thing I can say is what made me have that decision is that I didn't want to be put into a coma. You know, when people are getting put on ventilators, they have to induce a coma, put tubes down their throat, and all the rest. And in my mind, I just said, no way, I am not doing that. My nurse came over to me and they said, John, calm down. They're just trying to help you. And I just said, no way, I am not going. So I was really insistent. And all I asked them to do was, thank you. All I asked them to do was sit with me for a little while and help me get through it. And I just kind of said, I'm going to will myself through this. I'm not going anywhere. And about 45 minutes later of being in really bad shape, I mean, I had the chills. So I was getting the chills every day, but that night, the chills were so bad. I had 9 blankets on me, those hospital blankets. I had 9 blankets on me, shaking. And just after about 45 minutes, I just felt myself coming down. My heart rate started normalizing. My fever started normal. Everything started coming down. And I looked at the people and I was just like, thank you, but I think I'm going to be okay. And now looking back, I think that was my peak, because I had been getting worse and then I kind of leveled off. And for some reason that night, and I think it was brought upon by that albuterol treatment that just kind of had a bad effect on me. But I think that was my peak. And every day after that, and that was day like 13. After that, every day after that, I kind of got a little better where my temperatures weren't so high, or when I was getting the chills, I was getting them for an hour at a time or hour and a half. And that's a long time to be in that state. It was horrific. But I noticed them lessening, and I could almost put a clock onto when I was going to get them. It was always around 6 o'clock at night where I would get this little spike, I'd get the chills, and then I would watch the clock until, and it was getting less and less. It was an hour, it was 45, it was a half hour. So I knew in my mind, okay, I'm getting better. And that was really, for me, my psychology, for my psyche, it was just good news that I felt like, okay, I'm going to get through this. And every day, all I could watch on TV was all these deaths and all these people dying. And I just had to turn the news off after a while because I couldn't watch it anymore. It was just really depressing. But in my mind, I said, okay, I got through cancer. I'm going to get through this. And 3 days after that incident with the respiratory team, they had told me I could go home. Now, unlike Evie, you said you lost your sense of smell and your sense of taste. I didn't. Now, I know what that feels like because when I went through chemotherapy, I did lose my sense of taste, which is common with chemotherapy. You lose your taste buds. So I know what that was like, and I did not do that. And talk to people that were going through it, and it just seems like everybody had different symptoms. Some people had the aches and pains. I didn't have the aches and pains. I was having headaches. I had the fevers and the chills that were horrible, like really bad cases of chills. I had the coughing that was incessant. And after the temperatures went down, and I basically was virus free, according to my doctors, the pneumonia stayed in my system for probably 2 to 3 weeks. I was coughing it felt like 3 full weeks. And by the way, this isn't something else to note. I stayed in quarantine in my house for a full week before I went to the hospital. My wife coming down to feed me with masks and gloves. And that's the only contact I had with her or my son. My son would open the door, wave to me, and close the door. Literally total quarantine. And they never got sick. And they both went for antibody tests, and they don't have any antibodies. So they did not get sick. So really being strict about the quarantine obviously worked, because you said in your household, everybody got it, right? It was just one of those things. For me, as soon as I got my symptom, I went directly into quarantine, and it worked. I don't know why. I don't know, doctors, you could answer this. I don't know what the incubation period, but I saw a lot of people between Sunday and Thursday when I got my first bout of symptoms. Also going on like now after I come home, it's free. I'm considered recovered. And actually, on a side note, I was the first New Jersey resident to be considered recovered. And that was, a thing that back then. It was only March 18th, and I was fully recovered already. This is basically the pandemic was just starting, and I was already through it. So whatever. But I came home, and I went back down to my family room for another 3 weeks while I coughed and got through the pneumonia. My wife, again, I hadn't seen the upstairs of my house for a full month before my wife was letting me come back to the kitchen to have dinner with them. I mean, it was a full month, maybe more, maybe 5 weeks to be exact. But that was really us being diligent. And my wife coming down, Lysoling everything, just really being diligent, I think stopped the spread for us and the family. Small family, just a wife and son, but still stayed away. And I think that's what got us through. So finally, after about 3 weeks, I felt the pneumonia that was finally starting to get through. I went to see my doctor. He did chest x-rays and not x-rays, chest exams, and he felt like I was getting better. So it took almost a full 5 weeks before I could say that I was pretty much done with it. Since then, so we know I probably got it because I was immune compromised, most likely. Why anybody else at the bowling alley didn't get it that night, probably that's the reason. My wife is very diligent about germs and people. Nobody's allowed in the house. She does all the shopping, and she comes home. She puts everything out on the deck, sprays it all down, wipes it all down before it comes in. She's incessant about me not touching any mail or any, like she sprays down cash, money from the ATM. She comes, puts it on the deck. She sprays it down. So she's gone to the nth degree, but I have to thank her because she got me through it. And obviously she doesn't want to get it, or she doesn't want me to get it again. And we don't know yet how it handles people that have already had it. I did get my antibody test, and the doctors at the lab came back and said I did have antibodies. Not a lot though. They were specific to say you have some antibodies. Now don't forget, this is 2.5 months after I was done. So the doctors can probably chime in about that too. Do the antibodies wane as it goes on? 3 months later, I have some. 3 months from now, will I have none? So will I be at risk again, just like everyone else? These are questions that are obviously still going. Dr. Cheng, I see you shaking your head. These are things I'm sure you're studying. We don't know this. So my wife is basically saying, okay, even though you think you've had it already and you're okay, you can still get it again. So we treat every day like I can. And I don't walk around with the S on my chest thinking I'm Superman. I don't go anywhere without a mask. I'm very diligent about that. The only time I actually exchange with people is on the golf course. I do play golf, but that's outside and we are spread apart, and I do take my own cart. So we're social distancing even on a golf course, pretty much. So that's the only time I'm allowed to see people. Other than that, it's just my wife and my son. I work from home every day, and that's been going great. I have no complaints about that. I have my own little office up here now. But the thing that I can stress is the masks. I know there's both ends of the spectrum. People wear driving cars, which I don't get that, but I see that and I don't judge. That's, if you want to wear your mask in your house and all day long if you're alone, that's your prerogative. Then there are people that don't want to wear masks at all because they think that that's infringement on their rights. Well, I get that too. Don't get me wrong, I do get that. But I think personally it could help. As we know, putting a mask on, having two people talking to each other with masks on is obviously going to help. And it's a small sacrifice to make for the betterment of our society. And I don't think that big a sacrifice. So we're doing it, and we're keeping that up. And that's about it. Right now I am 3 full months, almost 4 full months out from where I started, and I'm back training. I was supposed to do an Ironman this year, and that got canceled. although I wouldn't have been able to do it. There's no way I could have done it this year. My, I'm running and I'm biking, and most people say, "Oh, John, you're back," because I see you running 6 miles a day, but that was a warm up for me, a few months ago. So I'm not 100% yet. I know how fast I can run. I'm not running that fast yet. I know how long I can run. I'm not running that long or biking that long. So am I better? Definitely. I'm definitely better. But with me and my specific athleticism, I know that I'm not 100% yet, but I'm getting there. I do track workouts on Tuesday where I'm sprinting for a quarter of a mile, and I can do that now where I couldn't even, come close to that. So things are going in the right direction. I'm progressing every day, getting stronger every day. And I deferred my Ironman till next year. So in January, hopefully I'll be able to start training again and do that. So so I think being in good shape also has a lot to do with it. As we know, pre-existing conditions like heart problems or being obese or anything, diabetes, everything like that can cause problems. Obviously, having cancer was my pre-existing condition, but I think overall being in good, healthy shape got me through it. My lungs are in good shape. I could run a marathon, tomorrow probably. Wouldn't be very fast, but I could do it. I feel like I'm getting to that point where I could push the mileage. So that probably helped me get through the respiratory issues I was having. When I got COVID, I was in the midst of Ironman training because I was supposed to do one this year. So, I think being in good shape definitely got me through it. And I would stress that for anybody that was having problems or going through it. Try to act like you said, Evie, Chris Cuomo helped you get up and get moving. I think that would help if you can. I mean, obviously some people can't do it. When I was in the throes of my worst part, I was in bed the whole day. I mean, I could not get out of bed. So as much as I wanted to, I couldn't. But if you feel like you can, yes, definitely get up, walk around the house, move your body, create some lung capacity, and I think that would help. So having said that, I thank you for your time, and I was happy to share my stories with everyone. Thank you, Lopa.
Thank you. Thank you so much, John. That was so inspiring. I mean, really, we
all
need to clap for you. Like, you overcame COVID, and the situation you went through, we hear that all the time, but to come out of that, and as you said, exercise, and because you were healthy at that time, and that really helps, as Evie also mentioned, and the way Laura brought in her perspective from the, being a cancer survivor standpoint, plus how to safeguard yourself, and when you face it, how to overcome it. Thank you so much, all of you.
We don't know a lot yet, obviously. The doctors.
Yes, we don't know.
So I can't tell you definitively that, me being in shape, got me through it. I don't know. But the only thing I'm going to do is guess and say, I think that's why, and these are theories. That's why I thought the theory of me being, when I first was symptomatic, that's when I was, quote unquote, contagious. Because until I got my first symptom, like I said, I was around a lot of people. I shook a lot of hands at the bowling alley that Tuesday night that I went there. I was sleeping with my wife in the same bed. My son, I see, nobody got sick. So why was I for 4 days, incubated and not contagious? And then, obviously I didn't give it to anybody after that because I was quarantined. So these are all theories. So my theory is that for me, we weren't symptomatic. If you weren't symptomatic, you weren't contagious. Now we know probably there are thousands of cases unlike that, but this is all we can do is just try to put the data together and guess.
Yeah.
So
no,
that was
absolutely.
one of my theories.
Sure. Thank you so much for sharing this, John. So the next, I'm supposed to speak, so I'll be very quick because mostly everything is covered. And so that, I'll try to wrap up in 5 minutes so that we can come to the question answer sessions we have. So I'll try to share my screen here and I can go from there. So can you all see my screen?
Yes.
Okay, perfect. So I think what I'm going to cover a little bit is, because I know Dr. Cheng, Dr. Park, and Evie, John, and Laura have instilled everything upon us, like they have enlightened us with all the perspectives. And I'll just try to bring into a little bit about inflammation with COVID cancer, because inflammation, as we know, that plays, like, it has a dual role. So inflammation is needed because it helps with the repair in the body. But at the same time, if inflammation goes out of control, then it causes damage. And the reason why I want to talk a little bit, because my work focuses a lot on inflammation. And one of the inflammatory conditions that we discovered, that's why I can authentically report this. And that's the only slide I'm going to report with the authentic data, that it was our work where we found the relationship between arthritis and breast cancer, where with arthritis, and if we have breast cancer, the metastasis is significantly higher compared to the non-arthritic condition. And we figured out that there are a lot of inflammatory cytokines like IL-6, IL-17, TNF-alpha. I don't want to go into any, I'll be in a very layman term, I'll explain. But these pro-inflammatory cytokines are upregulated with arthritis in a huge amount. And what happens is when we have cancer or other certain pre-existing diseases, we have a low grade of inflammation, because if we have a tumor with cancer, the tumor microenvironment, it itself by itself creates like tumor-induced inflammation or therapy-induced inflammation. Or if we have some autoimmune diseases like autoimmune arthritis, this also contributes towards inflammation, which helps in the upregulation with many signaling pathways. So that's why, you know, like I want to talk about a little bit about inflammation and its role, and how through diet, through exercise, we can help ourselves, because this is the COVID scenario. Now, why I am bringing inflammation into the picture, because we want to know about pre-existing diseases, but also now we all are also aware of COVID-19 cytokine storm. So what happens is COVID-19 infection goes through different stages, and when with the lung, and there's so much inflammation, and that's why now a lot of times we are targeting basically inflammation with our treatment therapy. So with COVID, what we found that, you know, like the COVID virus, basically there is an ACE receptor. This is one of the pathways that scientists figured out till now. You know, there'll be multiple pathways. So I want to tell you one thing, like studying cancer cells, and I'm sure Dr. Park will, advocate for that. I always thought that cancer cells are the most tricky cells. We try to target one pathway, that another pathway overtakes it. But seeing the situation with COVID, like, you know, we are all blown over, like what is going on and how we can help ourselves actually to help others too. Now with this situation, we have figured out one pathway that I have taken data from different places, authentic places, and we know that this is the ACE receptor, ACE2, which is actually angiotensin receptor, which is called angiotensin converting enzyme 2. So why am I talking about this? Because ACE2 is present in many cell types, including the lungs, heart, blood vessels, kidneys, liver, and gastrointestinal tract. Now, when the COVID actually attaches, it's like a lock and key theory. The virus binds to the ACE2 receptor, and it prevents performing, like it prevents the normal functioning of ACE2 to be so that it regulates. Thank you so much for those. If you could please mute yourself, that would be helpful. So basically the angiotensin signaling pathway is being blocked, which the activity of ACE2 is blocked because the COVID goes and binds to it. Now, when it is when this pathway is inhibited, because angiotensin, ACE2 signaling pathway, what it does is it actually it blocks it destroys the angiotensin molecule, which has further downregulation pathway leading to inflammation. So when the COVID goes and binds to the ACE2 receptor, it blocks that particular pathway, which kind of aggravates the inflammatory sequence that follows thereafter. So this is a simple way why we can think now that, you know, like why, like with the lungs area, right? When the virus is entering the nostrils and it's giving some time for our immune system to combat, but then finally, like there are the ACE2 receptors in different organs, and especially lungs, it's like penetrates there and tries to damage it. And then when and what happens is when with our inflammatory response, there's a huge, like even our immune system can't recognize like what to do. You know, that's when the influx is severe, and that's when the cytokines, they get upregulated. So this is basically what happens in the background from one of the pathways that is out in the different authentic journals. But you know, with COVID, as I said before, so much is unknown. So what will be the next sequence, we don't really know, like as the scientists go on working on it. Now, I would just like to address few key factors which we can target, you know, to help reduce the inflammation. So one will be the diet, because we know, like we have been always talking about eating healthy. But why eating healthy? Because the antioxidant-rich diet. Now, what happens is in our body, automatically there are free radicals which are generated. But there are antioxidants which will give one of the radicals and balance the free radical, because these free radicals goes and damages the DNA of the cells, which will lead to cancer and other different ailments. Now, what happens is, why we need the antioxidant-rich diet? So that it can balance the free radical, because endogenously inside the body at times is not enough. And that's when, you know, when we eat unhealthy, like the diet, it kind of aggravates the system inside the body. That will be not a good phenomena right now when we are already exposed to COVID every now and then, because we really want to do our best to help our immune system. Now, stress is also a master regulator for many pathways and definitely inflammation. And what happens is, I always say, like as Evie mentioned, as John mentioned, that exercise, it definitely plays a very important role, because there are many like molecules that different, I don't want to go into detail, but there are different molecules, endomorphins and others, which are, gets into upregulated form. They help with the stress also. And I'm not saying that you go, with the COVID, you want to go biking without mask, but I would say that at least do a 30-minute exercise at home. Get your body moving every day, like yoga helps, and to release stress, meditation helps. These are natural ways where you will see that it makes a difference. And other factors are like alcohol, smoking, like smoking, nicotine-based, tobacco chewing, which is very prevalent in India, especially in Northeast India. So we should understand that all this that we are putting in our body, they're contributing towards our immune system, which eventually will lead to how we are fighting against the diseases. And it's not only about the time being, even these are like tobacco, like nicotine, these are carcinogens which we are putting directly inside our body, and it affects the whole body. Then alcohol, because alcohol also triggers a lot of inflammation in the intestines. So these are different ways. I wanted to just give a glimpse of it so that you are aware, that just smoking is a total no-no in this situation of COVID, when we know that COVID virus loves lungs. So that's why, I'm again requesting, please, if you find, and if someone is smoking in front of you, you should be not there too, because if you are inhaling the same, that will also have an effect. Saying that, like obesity, we really definitely need to, so these are the different criteria, I would say, that what we can do, with the COVID, like to our best, is exercise, control the stress. I know it's not possible to control stress, but we do our best by, with exercises, or, like at least we can do chat with our friends. Like we don't need to have a party in the weekend. And I heard about the COVID-19 parties in US, which is very prevalent now, and which kind of like a host is a COVID he is a COVID patient and who is actually hosting a party, and that is like aggravating like anything in different places. And then the youngsters, I know they want to go out, they want to socialize, but we cannot think about ourselves right now, because our responsibility is not about us, it's about the community. So we have to really, whatever the doctor said here, whatever the survivors, everyone talked here, please, spread the word out. Watch your weight, because obesity, there are a lot of underlying inflammation going on with obesity, and also with the diabetic situation. So controlling the weight is very important. Please stay hydrated. Hydrated, I don't mean that the soda and all of that. Please, hydration means like water or green tea, antioxidant rich, which are natural, and no processed food, like canned food, lot of sodium. All of this will not help right now, because you really want to keep your body healthy. Then vitamin C, vitamin D, A, E, and zinc. These are the different vitamins, and zinc definitely plays a very major role in the antioxidant category. So please enrich your diet with all these factors, which I cannot guarantee, but we are doing the same for our family, and I'm sure it's going to help, because healthy lifestyle helps in every case. So these are the different diets like which plays a role in inflammation. Like we all know about turmeric. Turmeric, the byproduct of turmeric is curcumin. I would request that, you know, get curcumin in your diet, but I'm not in favor of any capsulated form, but the natural form. Ginger, onion, garlic, and also like I'm not in favor of the paste. You know, we get all this concentrated paste in the market, or ginger powder, garlic powder. I would say use the fresh ones, because that really are anti-inflammatory, and this will, I won't say that it's going to help us to not get contracted with COVID, but this definitely helps with fighting back, you know, because you really need to fight back if we are exposed to. And these are the different food, tomatoes, berries, and I know you all are aware of this, so I won't go into details, but they have their own ingredients, and which really definitely helps. And also these are other and more anti-inflammatory food, like the sweet pea peppers. Capsaicin in the pea pepper is highly anti-inflammatory, but also I would request that, you know, don't have it so much that you get gastric ulcers. So you have to have a balance actually, which will really help. Now, this was a little bit about what I mentioned just now, was about how we can target inflammation through our daily lifestyle so that we are helping our own immune system, because definitely we need to boost our immune system through our exercise, through different forms, through our food diet, to fight the COVID and also fight different pre-existing diseases that we carry, if we carry any. Now, before signing off from my talk, I just want to also give you a reminder about, I know that at this situation, because it's breast cancer hub, we do a lot of research, a lot of awareness screening with breast cancer, but now we are diving into all other type of cancer. Our support group is amazing. We have like everyone, and we have many here in the session also today. So, but I just want to give a reminder check that please, I know that now even I couldn't go for my regular mammogram this year because of the COVID, but that's not a good idea, because 1 in 8 women can get breast cancer in their lifetime, and even men can get breast cancer too. So what we have is a solution for the rural sectors or in the underprivileged sectors who cannot go over the screening, is the breast self-exam card, which we produced in collaboration with Male Breast Cancer Coalition and Sarah Cannon Cancer Institute. So please go to our website, download the card, and do breast self-exam for yourselves, because at this situation, even if you can't go for screening in the hospital, but at least check yourself as a reminder. We have it in 17 languages, converted by our wonderful BCH volunteers, translated. So please share it in your network and give a reminder to your family, because the breast self-exam cards really work. Because I have been using it in all the outreaches, screening camps in India, and even in US also, people love it, because younger women can get breast cancer too, and men too, like 17 to 18 years. I request everyone to go do the breast self-exam card every month, and even if you cannot miss that too. So this is like, you know, the outreaches that, you know, just a representation, but what I'm saying is, if you feel any lump, please don't forget to inform your healthcare provider, because in this full COVID situation, there are cases where new detection is happening, and definitely you have to keep a check on that. That's my request, you know. So keep a check. If you feel any abnormalities, please report to the doctor, because we are overseeing other pre-existing conditions or other screening processes because of the COVID. And that's with that request, I would like to end my talk, like where I'm putting together inflammation, role of diet, exercise, stress, how within our daily life we can help our immune system to fight back. And on behalf of Breast Cancer Hub family, I want to thank each and everyone, and a big thank you to all our speakers for enlightening our participants today. And we are so grateful to you all for giving us the time. And we really appreciate all the participants here who patiently listen to us. So,
yeah.
yes. Sorry, Sandeep.
Yeah, there were, only 3 or 4 questions. So Dr. Cheng and
I will stop sharing
if you don't mind, like maybe we can quickly cover those 3 or 4 questions that we have from the participants. That will be great if you don't mind, staying for another 5 minutes. Okay, so there was a question around the cloth mask versus the N95 mask. Of course, those specialized masks are not available in the market. Are the cloth masks effective enough that we can use them?
Yeah, I think it's a great question. The short answer is yes, because what you're trying to reduce are the larger respiratory droplets that are coming out of our mouth and nose. And these cloth masks, they don't sort of filter out the 5 micron or less, the aerosol stuff, but they certainly filter out some of the larger stuff, and it gets stuck onto the cloth mask. So anything that you can do to sort of prevent things coming out, whether it's a cloth mask or whatnot, is going to be very helpful. I'll give you some sense of how significant this is. The CDC director 2 weeks ago was during an interview with the JAMA editor, basically said that if everybody in the United States started wearing a mask, we'd be able to get a handle and control over this pandemic in a matter of weeks to months. So it's a very, very important thing because of the asymptomatic spread. You don't know who's infected.
Yeah, thank you. I think the second question was,
is it necessary that we all should wear N95 mask, or just any cloth mask, the 3-layered one, and all that will do?
Yeah, right now the current guidelines is not for everybody wear an N95 mask. That's not necessary, especially for healthcare workers. That's a different story. But for the general public, cloth masks are sufficient. You'll notice people don't talk about these cloth masks as calling them PPEs, personal protective equipment. They're called source containment equipment because you're trying to contain the stuff from yourself and prevent that to spread to others.
But we wash it, and it can be sterilized also.
Yes.
I mean, 10 minutes if you boil in boiling water and take it out.
Frankly, or just leaving it out in the sun and exposing it in the sunlight for several minutes or even an hour.
Plenty in India, we get a lot of sun, at least, thank God. You got a lovely rainbow at the back. Is that this thing, or are you sitting outside enjoying the sun and the rainbow?
No, more the former than the latter.
Lovely.
So,
Dr. Cheng, one more question.
Sorry,
One
Sandeep,
more
I
question
just want
from Dr. Das, and it is regarding, when the patients, they go through the serious conditions and they're put on the ventilators, is a byproduct that when they are on the ventilator for 2 weeks, is it the secondary type of infection that is kind of causing the casualties, or is it the primary COVID-19? I think that was the question from Dr. Das.
Yeah, I think it's a great question. Ventilator-associated pneumonia, which is that secondary type, is not as common in terms of the people sort of dying on the ventilator. So most of it is when people have bad enough pulmonary disease from COVID that requires them to be on the ventilator, they're at risk for developing what people describe as acute respiratory distress syndrome, ARDS, ARDS. And that's sort of just an overarching damage across the lungs where ventilating. So the difference between breathing on a ventilator versus breathing yourself is you're actually on a ventilator, you're pushing air into the lungs. Whereas when you're breathing, you're taking a deep breath and you're negatively inspiring. And so the actual pushing of the air into the lungs when it's already partially damaged by the infection can actually cause more damage. And that's one of the worries.
Right.
Makes sense.
Thank you.
Okay, perfect.
Yeah, I mean, we had a very great friend of mine. He had a stent in his heart a couple of weeks ago. And I think he was asymptomatic actually, but suddenly he developed very chronic conditions and he was rushed. But within 2 days, he had gone. So does the heart, when you have a stent and all that, does it affect, you think? I mean, they get affected?
Some people who have stents have normal heart function, and they're fine. It's really the impact that the heart disease has had on the heart, not simply because you have a stent in place.
Okay, because he had a big belly, maybe, I don't know. And he got into yoga practice, pranayama and all off late, like about a fortnight back, but we lost him day before.
Sorry to hear that.
Really sad, suddenly. And Lopa?
Yes.
Are you there?
Yeah.
Even Bhumika lost a father-in-law, COVID-19 at Ahmedabad.
Oh,
He was a throat cancer survivor, right, for almost 10 years.
Yeah.
and which hit him badly. So remdesivir, everything we organized, but nothing.
Doesn't
He
work.
just,
Yeah. So just to an introduction. So the person who is asking the question is Mrs. Uma Pai. She's from Bangalore, and she is a breast cancer survivor and a very integral part from our breast cancer health support family group. Thank you, Uma ma'am, for the question.
only 20 years, only 20 years. So everybody should get that positive thing, you know, okay, you have overcome and you can overcome.
Yeah, exactly. Yeah, one last question, and maybe this is for Lopa, Dr. Cheng, whoever wants to answer this. I was also from the participants, and this is a curious question in my mind as well. We go to the grocery, we bring the grocery, you know, we go through like 2-3 steps of cleaning, especially Lopa makes it super harder for me. So yeah, like I'm kind of wiping on everything. Any general guidance from you guys on what should we do when it comes to the fresh produce versus the regular grocery versus fruits and veggies? So like just some general guidance for the audience here.
Yeah, I would like to let Dr. Cheng and Dr. Park answer to this question, because you have already explained what we do at home. So.
Yeah,
it's
so
it's better to be good, you know, than being sorry later. So it's okay. Yeah. Dr. Sandeep, I think we should listen to Lopa.
Yeah, Ellen, go ahead.
Yeah, I think it's a great question. Unfortunately, there aren't any sort of guidelines or general instruction on doing this. There was a news piece in the Washington Post that was published a couple of weeks ago where they interviewed 5 prominent health epidemiology, infectious disease folks. Dr. Fauci, as you guys have maybe heard on the news, is one of them. I can send you the link on that. And they asked very pointed questions like this. So I'll tell you what we do. So for when we bring in the mail, we usually just let it sit for a day because mail is not urgent and there's no point. COVID, at least from some of the studies, shows that when you're on cardboard or paper material, the half-life of this stuff is roughly a little bit short of 24 hours. So usually if there's any virus, it's going to be gone. So we bring the mail in, we let it sit, and then the next day we open it, for that matter. For the groceries, as you know, much of the cold stuff, that's the environment that COVID tends to survive longer in. And
Yes.
so my wife tends to bring in the groceries and wipes them all down with an alcohol-based wipe. And then we bring them into the refrigerator in that way, so that we minimize the amount of transferring of these things. Now, keep in mind, you can go crazy and go nuts and pull your hair out with all these different things, and it's not entirely clear how much of this will be helpful, because we do know that fomite transmission, this is what we talk about when we say fomite transmission, how much of the virus on objects can be actually transmitted is actually very low. So even if you're not doing all that stuff and you bring the groceries in and don't wipe them down, the way you get infected is not that the virus jumps from the packaging into your nose. It's getting it on your hands and then you rubbing your face and rubbing your nose and eyes and things. So if you're very careful about handling these things, washing your hands before you start touching your face and any other part of your body, then there's no way in terms of which you can transmit that stuff.
What I do is I wash it with white vinegar, run a lot of fresh water down, and like on a colander, I leave it, whatever I bought, I leave it out 3 to 4 hours, and then only wash my hands again, and then try to sort it out, and then put stuff what goes in the fridge. And we're really avoiding cold meats and what has to go in the freezer. We haven't been even ordering from outside, all home food, all home cooked, basically veg food.
Yeah.
Good.
And eggs, of course, for protein.
Thank you, ma'am. Thank you, Dr. Cheng. So, Sandeep, any more questions in the forum, or you can directly ask also to the speakers if you would like.
I think that was it. Those were the questions I found on the chat window.
Sandeep, maybe I'll just one more point that I think Evie brought up and a couple of other folks is this issue of immunity. Because it's a really, really important point, and I appreciate some of the comments that John made. And John, you and your family arguably are a testament to how things go the right way, and exercising the right precautions
Yeah.
because we don't know, to your point. You know, coronaviruses in general are like the common cold. And you know from your own experiences, if you've had the cold once, you can get it again. And that's the worry about COVID-19 being a coronavirus. We don't know if once you've had it once that you're immune. So let me just share one quick slide, and I apologize for taking so much time here, but let me just share one slide to give you some sense of what
Another
this looks
question
like.
I had, Dr. Cheng, is about homeopathy. Because a lot of us in India started taking this Arsenicum alba 30, which they say builds up your immunity. So does homeopathy have any strict effect on containment or on immunity building? Does it work?
Yeah, I can't comment on the homeopathy stuff because there aren't any studies that people have done as much as they had on medications and things. So,
Yes.
so I apologize. But can you guys see my screen here
Yes.
Yes.
on the graph? So what this screen shows is sort of the natural progression of what happens to the PCR testing and our antibodies over time from the time of infection. So this dotted line here is when someone who, let's say, is infected with COVID would start developing symptoms. And as you know, and as John mentioned, you know, up to 2 weeks beforehand, someone could have been exposed. And that incubation period can be as long as 2 weeks, although on average, it's usually 5 to 7 days. And so what ends up happening is that once you get infected and the virus starts to sort of replicate in your body, the PCR test, the viral load starts to go up. This is sort of PCR, sort of samples coming from your nose and mouth. And this is sort of virus isolated from your respiratory tract, like in your airways and things. And you can see that the peak of the virus detection is really around the time of symptoms. And I bring this point up because, you know, let's say you got exposed and the next day you say, I got to run to my doctor to get a test right away. Well, if you do that, there's a really, really good chance that your test is going to come back negative because it hasn't had the time to really generate the amount of virus needed for the test to actually detect it. And then it starts to peak a couple of days into the first week, and then the virus sort of PCR starts to die and level off over the next several weeks. Now, the other interesting thing is John mentioned antibodies, right? So the antibodies are produced by our immune system in response to fighting the infection. These don't show up for another week or two into the time course of the disease. And it starts to peak, but then what you can also appreciate is that it doesn't just hang out and stay flat across the board. It starts to wind down, and we don't have, unfortunately, enough information to know how long does it wind down and start to plateau, or does it sort of really start winding down and go to zero, suggesting that you don't have any immunity? So that's where the challenge is, to really understand how much of this really lingers around where you do have some immunity. Everybody's behaving, and appropriately so, like John was mentioning, as if they don't. And because of that, it's all the more important to assume that you can get it twice until the scientists prove that you can't.
Doctor, I had a question about the, you know, you spoke about the heat and the humidity and how the virus doesn't like the heat and humidity, but why are we seeing hotspots right now in probably the most hot and humid states in the country, Texas, Arizona?
Yeah, it's a great question.
India,
and
India too.
Exactly.
Yeah, it's a fantastic question. And, you know, one of the main hypotheses driving out right now is, you know, heat and humidity and UV are great to combat the virus, but too much heat and humidity will actually drive people indoors in air-conditioned rooms and in enclosed environments. And so you're almost sort of like Goldilocks, right? You want just enough heat and humidity and UV to kill the virus, but too much of it will drive you and me into the air-conditioned areas of the world.
But AC is not advisable, right? AC is not advisable. Staying in AC is not advisable.
Yeah, it's not advisable because you're in the 3 C's, right? You're in these closed environments, you're in crowded spaces, and you're having conversation across small quarters where you're circulating aerosolized virus. And so so it's a balance, and that's one of the hypotheses why Florida, Alabama, Texas, lower parts of California are really seeing these upticks.
Thank you, Doctor.
That's why we always make fun It is not now work from home, it is work for home. Because we all are doing a lot of work here in India, which we're not used to, sweeping, swabbing, washing vessels. So work from home and work for home it has become now.
So any more
Thank you very
questions from our participants?
I have a question.
Yes, sorry, we have a question from Shalini. Yes,
Yeah.
Shalini, go ahead.
Yeah, I have a question, Dr. Allen. Like, what is happening is like people take these tests, as you mentioned, in the first 2 weeks, and they come out negative, and it is almost like getting a gold medal in the Olympics. Like, I'm negative now, so I can do whatever I feel like. And this is causing a, you know, like sense of illusion that as though we are like clear of it, our family doesn't have it, our neighborhood doesn't have it. And so how do we tell others, like how do we have compassion and how do we protect ourselves from such people around us?
Yeah, it's a great question. And so, you know, first and foremost is the face mask and the social distancing work. They really, really, really do. And I know it's a challenge, especially in some folks who believe that, you know, their personal liberties are being violated. And, you know, you may think in the back of your mind, you know, these people are crazy. These people don't know what they're talking about. Just, I would maybe suggest, you know, we extend a little bit of grace and compassion in these folks, because what ends up happening is that, especially in situations where we don't have control over the environment, we resort back to our sort of fundamental beliefs. And things that we do believe are important. And so having control over what we do, having control over what the situation is sort of one of those things that people do. And personal liberties is one of those things psychologically that people believe as having control over your own situation. Now, with that said, you know, this is the reason why at least the public health folks say, even if you've gotten tested negative, so if you've been exposed to someone who's had who is positive for COVID, they still recommend you do the 2-week quarantine, even if you've had a negative test, because you have no idea whether or not your test being negative is falsely negative or you truly are negative. And so that's why most people who otherwise feel fine, let's say if I saw John and John was sick and he tells me a couple days later that he had COVID, I might not even get tested if I'm comfortable just getting the quarantine for 2 weeks. Because regardless of what the test tells me, I'm still going to quarantine myself and keep myself isolated. And so it's exercising face mask use, exercising social distancing, and then the 2-week quarantine, regardless of what the symptoms look like.
Thank you. That makes sense. Yeah.
Yeah, that's why never rush. Colds come and colds go. Whatever you do, it stays for 7 days, cold. So take it like that, with a pinch of salt, as we say. Thank you.
Thank you. Thank you, Dr. Cheng. Thank you, Shalini, for the questions. I think we are good with the questions, and if you have further questions, we have another question here from Dr. Imtiaz, and thank you so much for the question, Dr. Imtiaz. And his question is, would you like, okay, how much chances for getting infection again in recovered patient? That's a great question. So, Dr. Cheng, what are the chances for getting it back? So.
Yeah, and it's we were just briefly talking about this. For the individual who got infected, the chances of getting it again are not clear. Last week, there were a couple of reports, one in the US and another one in Spain, showing that people had bona fide second COVID sort of syndromes. So very, very early on in March, they showed that in Korea, people who got infected tested positive, and they tested negative, and then several weeks later, as part of surveillance, they found PCR in their nose, but they were otherwise fine. And the thought behind that was that these folks probably had some remnant viral material, but weren't emitting it or spreading it. More recently, these two sort of case studies are showing that there's actually a group of folks that might be getting it again. And so these are people who got it, they tested positive for COVID, they recovered, 2 to 3 months later, after being fine and feeling well, get it again and get sick. And in some cases got sicker the second time versus the first time. And so I think the jury's out in terms of what the chances are, but it's clear that there are at least some cases of this It's not clear if it's a rare case or this is part of the rule. So we'll have to see over time.
Thank you. Thank you, Dr. Cheng. And I hope, Dr. Kamar, we answered your question. So I see one question popping up on the chat area from Bhavna. And her question is that if we have a combination of cancer and COVID-19 at like someone who is an active cancer patient who is undergoing chemo and also affected by COVID-19. So what shall we do?
It's too bad Dr. Park isn't on the phone anymore, but he would probably be the best person to answer this question. But I think, much of the comments that he made were really focused on the fact that you're immunosuppressed with some of these agents, and then you have an active breast cancer or a cancer that's ongoing. Lopa, maybe what we could do in terms of just recommendations is maybe we can email him and then get his response and then get it back to the group.
Yeah, I will do that. And also like Bhavna, I think I know Bhavna's case. So Bhavna is also a part of our support group, and she's here for her mom who is going through colon cancer. So Bhavna, basically, I would always say that keep your mom's immune system as much as possible. It's a very unavoidable situation right now. And what best we can do is to help ourselves so that, your mom doesn't get contracted with COVID in this scenario. So I know she's still doing good, and just help her. And I have mentioned about all the processes, and even Dr. Cheng, Dr. Park, how to save yourself from the exposure to COVID to the best of our possibility. And I'm going to address the question to Dr. Park, and I'll get the answers for you. Thank you so much, Bhavna.
Thank you so much.
So sweet.
So I think.
Oh, so there is another question.
I just want to be mindful of time and then for everybody. I know you have to probably run to your own commitments. So why don't we wrap up for today? And again, like in another 2 months time frame, if we have to do another touch base, we can certainly do that. We can, again, things are changing rapidly every day, every week. I would say that there were going to be new emerging things and new development. Yes, as our doctor said that the vaccines are pretty far away, and we just have to manage and maintain our lifestyle and do our best so that we stay away from this infection as much as we can. So we can definitely do a touch base in another, and maybe the format a little bit where we can gather the questions up front. It's going to be more of a Q&A session. So it can be more information sharing and Q&A. We can definitely target that.
Yeah, and then also
for our winner, new normal. We have to start doing the new normal way now, living.
Yeah. Exactly. So what I'm going to do is we are anyways planning for in October, in the month of October, we are planning for more seminars on, because it's a breast cancer awareness month. So we will definitely have questions in there, but whatever questions we have now, so Sandeep and I, we are going to take them down, and we are going to, if we haven't answered yet, I know there are a few breast cancer questions too, so I will address to that, and also I'll take Dr. Park's opinion and get back to you all, because we have to be respectful for everyone's time, and definitely we'll reach back. And I think probably Sandeep, don't end the meeting, please, so that we can get all the questions.
You are the host, I cannot.
So we'll get all the questions.
Lopa, I got to run to another meeting, so thanks so much.
Thank you so much, Dr.
Thank you so much, Cheng.
Thank you. And thank you all for coming in, but we'll definitely respond to the questions that we couldn't answer yet because of the time constraint. Thank you so much.
It is proved that master of the house is the mistress, right?